Yeah, good evening, everyone. I am Dr. Rupesh Jain. I am moderating the session, and I would like to welcome you all for the present session, that is Update in Pharmacology. And for this session, we are having two distinguished chairpersons. I would like to introduce Dr. Sandeep Mukhopadhyay. He is
Hello.
presently working as a scientist E, that is the Deputy Director post in the Indian Council of Medical, Kolkata, and he is a distinguished personality in the field of palliative medicine. He has received 7 international awards and grants for research on pharmacology and supportive care. And he's a vice chair of Palliative Care Study Group of Multinational Association of Supported Care. And he has trained in palliative care at different prestigious institute of India like Tata Memorial Hospital, AIMS. And we are fortunate to have Dr. Sandeep in this updates in pharmacology. Welcome, Dr. Sandeep.
Thank
The
you, Dr.
other,
Rupesh,
yeah,
for your kind introduction and the kind words. Please proceed with the introduction of
yeah,
the artist.
yeah. The other chairperson is Mrs. Saroja. She is having wide experience as a pharmacist in the Department of Palliative Memorial Institute of Pharmacy. This institute is a pioneer in preparing and dispensing for cancer 7. She is participation in the conferences and the conduct Department of Palliative Care at Kidwai Memorial Institute. And she has designed CCEPC camps in palliative care to be 7
introduction.
request Dr. Sandeep to please introduce the speakers and proceed further.
So, Tim, can you start the video? I think the introduction is there for the first speaker.
Yes, sir. Evening. My name is Dr. Nikki Pease. I'm a consultant in palliative medicine in Cardiff, and I'm delighted to direct oral anticoagulants, or DOACs, in the management of cancer-associated thrombosis. So if we were to think about, we know that venous thromboembolism in mortality and indeed healthcare expenditure is the commonest cause of death in cancer patients undergoing chemotherapy. This used to be neutropenic sepsis. However, with advances in medicine, VTE is also considered to be the second leading cause of death in cancer patients, with cancer itself. Cancer patient through their cancer journey, cancer-associated thrombosis. So it's an increasing problem. This slide looks a little busy. However, I just want you to take a few things from it. Firstly being that the tumor site per se, as we can, risk of a patient developing a cancer-associated thrombosis with hematologic as a high so patients with distant metastases or advanced suggests that it's in the first 3 to 6 months following their cancer therapy. With this information, we could look at whether patients primary prophylaxis for cancer-associated thrombosis, so giving them anticoagulation some of you may have heard of the VTE risk prediction tool, or Karana score, to stratify patients to some index and their BMI, coming out with an overall score, and that is determining whether primary prophylaxis is useful. And at the moment, it's suggested that primary prophylaxis would not be appropriate for the vast majority of patients receiving systemic anti-cancer therapy. However, those patients perhaps with a high Karana score, it may be worthwhile giving prophylactic anticoagulation in the form of either low molecular weight heparin, vitamin K, or a DOAC, pending, of course, that they don't have any contraindications or increased bleeding risk. Now, if we were to go on to the treatment of cancer-associated thrombosis, and of course looking at where DOACs sit in this, according to the current evidence, where we pull together our clinical judgment, patients' values, preferences, beliefs, and of course the relative scientific evidence. And it's this was the anticoagulant of choice. However, what warfarin, patients had a high risk of recurrent VTE on. In cancer patients, this was up to 1 in 5 VTE event. We also know that in the palliative care setting, our patients have a high risk of bleeding. It's very difficult in palliative care patients to control the INR because of multiple drug-drug need more symptom control. There's increasing drug interaction. So therefore, we need to consider how appropriate or to what extent we can take the evidence from the DOAC trials and use it for our patient population. That's not to say we just need to remember that. We know that in palliative care patients, they are at risk of VTE. However, they are also at a significant risk of bleeding, sometimes up to 10%. Palliative care patients have several comorbidities alongside worsening renal and hepatic function. They struggle with poor absorption of drugs. And there may be multiple pharmacology and drug-drug interaction. So what does the PCF7 tell us about cancer-related VTE? What we found is that DOACs may be non-inferior, as in edoxaban, rivaroxaban, or indeed superior to low molecular weight heparin in reducing VTE recurrence. However, that was at perhaps an increased risk of bleeding, both major bleeding and clinically higher with edoxaban and rivaroxaban, especially, as I've mentioned, GU and GI cancers. This wasn't found with IAPCON. We have to look at the patient population that was included in that trial. So for now, palliative care formulary guidance, PCF guidance, is there are guidelines for CAT, which now include the use of DOACs for at least 6 months as an option in patients at low risk of bleeding. Okay. Risk factors for bleeding, as we mentioned, GI cancers, concurrent use of medicines that would impact metabolism. We'll come on to that in a moment. Thrombocytopenia and renal impairment, as you can see there. A history of bleeding. That might be a recent history of bleeding or bleeding a few in the past, but was significant. And then you need to think about concurrent antiplatelet medication and sites of other disease. Patients with any of the above are considered at high risk of bleeding, and low molecular weight heparin would be treated, again for 6 months. The situations where low molecular weight heparin would be preferred are, of course, your actively aggressive progressive cancers, patients with a poor performance status, and extremes of body weight. So you're looking at less than 40 grams or over 100. End-stage renal failure, because your DOACs are renally cleared and they are not licensed with things like nephrostomy tube and impaired GI absorption. Again, you'd favour low molecular weight heparins. DOAC pharmacology, as I've mentioned it, this is a busy slide. However, I want you to take from it just a handful of things. One is you can see the P-glycoprotein, which is a transporter, which allows for absorption of the DOACs. Medicines that interfere with P-glycoprotein, whether they upregulate it or downregulate it, will impact on DOAC effectiveness. Medicines that impact the metabolism of the DOACs in your CYP3A4 will affect the levels of DOAC. And for some, like rivaroxaban, whether it's taken with or without food, will impact its bioavailability. Finally, they're all renally cleared, and you need to consider to what extent somebody's renal function has deteriorated as to whether you would continue using them. So as I've mentioned, inducers or inhibitors of either CYP3A4 or P-glycoprotein will affect the level of DOAC. And we can see here that some of our supportive care medicines can affect those proteins. So as we come to determining the evidence-based management of cancer-associated thrombosis in individual patients, yes, we need to think about the evidence, as you can see here. We need to think about recent trial evidence and guidelines. And there are international groups things like the ISTH, ASCO, who are constantly reviewing and improving or addressing guidelines following the evidence, as does the Palliative Care Formulary, PCF7. We need to think about other factors such as drug-drug interactions, bleeding risk, and their weight. I've got an asterisk next to this 120 kilograms, and that's because increasing evidence is suggesting that DOAC is reasonable to use in patients at low risk of bleeding at weights in excess of, up to 140 kilograms now. We also need to think about the primary cancer sites and the status of their cancer. Patients who have a primary brain tumour are at increased risk of bleeding, as are patients with GI and GU malignancies. We also need to think about patient preference, cost of the medicine, their culture. Low molecular weight heparins are from porcine protein, and therefore for some cultures, low molecular weight heparins may not be acceptable. We need to think about the burden, benefit, options going forward and their comorbidities. And finally, we also need to think about their VTE history, previous clots, and the impact of the clot on them. The update does advocate using DOACs. It is a really good reference book for this. It's independent. It's an independent professional publication. Within this palliative care formulary, there's a really good table on the different DOACs with lots of useful information in it. Also useful is this update on the guidelines for the management of cancer-associated thrombosis, where each of the main international groups who produce guidelines have written guidelines are. So you will see information like this, where you've got the different groups, ASCO, ISTH, and other groups, where what their recommendations would be and what their provisos are. And also in advocating this article, this talk is short. It's about 20 minutes that have been given. However, there are certain cases in CAT, or things like superficial vein thrombosis, what to do if somebody reclots whilst on a treatment dose of anticoagulation, people who are at extreme weights or have renal impairment. And again, you have different groups and different guidelines which will explain to you what might be the best way forward and how to interpret that evidence. Thank you. I'll now be available for questions at the end of the session. Thank you.
So thank you, Nikki. Let's give me a chance to introduce Nikki, though I thought that this slide will come automatically, but anyway, I have to make it in this short period of time. So, Nikki is a consultant in palliative medicine and honorary senior lecturer in Cardiff University. Her present affiliation is Wellington Cancer Centre, Cardiff, UK, and she has a vast experience of more than 25 years in palliative care. Her areas of interest are cancer-associated thrombosis, communication skills, unscheduled palliative medicine care, and her major achievements are FRCP from London and MBBCH, MSc Palliative Medicine. And she has many number of publications in different national and international journals. And her session was on cancer-associated thrombosis, update on diet, oral anticoagulants. Our next speaker is, I'm just going to introduce them, and then the session of Nikki will be open for questions. Our next speaker will be Dr. Arun Ghoshal. Arun is a clinical fellow in Tata Memorial Hospital, Mumbai. Her present affiliation is University Health Network in Toronto. Her present experience is around 10 years. So far, I remember that he was the first batch of MD palliative medicine who did his palliative medicine degree from Tata Memorial Hospital, Mumbai. His areas of interest are palliative medicine as a clinical science, and he had done a number of projects with Dr. Navin Salins and others, and has a number of publications in different journals, international and national level of journals. And his session will be on urinary antimuscarinics. And the third session will be by Dr. Megan Doherty. Her present designation is and program director of pediatric palliative care program at Children's Hospital of Eastern Ontario, Ottawa, Canada. She has done CPC, and she is also affiliated to two World Cancer Collaboration Foundations. Her years of experience are more than 10 years. Palliative care in humanitarian setting, community-based palliative care models, cannabis and novel therapies for pediatric symptom control. And major achievements are executive member of humanitarian aid situation and emergencies. And her talk will be on analgesics for neuropathic pain in children. The next session will be by Dr. Arun. He will be talking about urinary antimuscarinics. But before that, the hall is open to Dr. Nikki for any question about the session on update on direct oral anticoagulants.
Dr. Sandeep, we will take questions after all the lectures.
Okay, so in that case, the tech
Yeah.
team, please move to presentation of Dr. Arun. Tech team, please move to the presentation of Dr. Arun.
Tech team, please play the video of Dr. Arun Ghoshaal's presentation.
Yes, sir.
Thank you for joining in the IAPCON Conference 2022. Today, this is about the agents for treatment of overactive urinary bladder. It's a therapeutic class review. I am Arun, and I'm doing a clinical fellowship at University of Network in Toronto. So let us move on with that. So what are anti-muscarinic medications? We'll start with that because today we are going to talk about these medications a lot. So basically, anti-muscarinic medications are a group of anticholinergic agents, and as the name suggests, they're known for blocking the activity of the muscarinic receptors. The other type of anticholinergic agents work on the nicotinic receptors. Muscarinic agents work on the muscarinic receptors, which play an important role in mediating the functions of the parasympathetic nervous system. And you know, it controls many involuntary functions, mainly for conserving energy, including the contraction of these smooth muscles. For example, we're talking about urinary bladder today. When the dilatation of the blood vessels increase bodily secretions, it works in the gastrointestinal activity and also on the heart rate. So in this diagram, you can see, I'll just click the pointer, you can see that how the mechanism works. So this is a nerve ending, as you can see. This is acetylcholine, and this is the receptor, the muscarinic receptor, and this is the drug which actually blocks the effect of acetylcholine on the receptor, and thereby affects blocking the downward activity of the acetylcholine in the cell. So basically, what happens are smooth muscle motility goes down, exocrine gland secretion goes down, and heart rate will go up. So what are the indications where you add this kind of medications? Apart from the overactive urinary bladder, irritable bowel syndrome, in bradycardia, in motion sickness, in Parkinson's disease, in peptic ulcer, in various respiratory conditions like asthma and COPD. As for any class of medication, these medications come with their fair share of side effects, which are dry mouth, sore throat, tachycardia, retention of urine. Sometimes we use it for our benefit. Obstipation, blurred vision, light sensitivity, mood changes, hallucinations, confusion, and even disorientation, also called as delirium. So today we'll talk about mainly focusing on the following medications. So the oral anticholinergics, or the first-line pharmacologic agents of this group, and commonly used solifenacin, dicyclone. The dosages and the frequency of usage are given in these books. And as we have discussed before, we know already these four medications. Apart from the medication, the bladder emptying agents, which are basically working in antagonism to the bladder muscle relaxant, and pterojosin. And we need to also know about the bladder medication, actually, which cause the surface irritation to come down. For example, phenazopyridine in overactive bladder, like rectal opioids, benzodiazepines, and others. Our focus of discussion today is dicyclone, but as good as the other medications which blood. About our focus of medication group today, which is anti the medication, the initial dose, the maximum dose that can be given, the adjustment needed for kidney or liver, geriatric population, any adjustment needed for CYP3A4 interactions. The first medication start at 7.5 milligram and go till 15 milligram once a day. If there is renal or hepatic dysfunction, it is recommended to stick to 0.5 milligram daily for moderate hepatic impairment. Mild, moderate, and severe hepatic impairment comes from childhood. Next one is initial dose, which is given 3 to 4 times in a day, and maximum dose contributing immediate release. 5 milligram started 2 to 3 times a day and go up to 4 times a day. In older population, is 2.5 milligram, and we can give 2 to 3 times in a day. Next medication, again oxybutynin, but comes as extended release formulation, which is given 5 to 10 milligrams once in a day and can go up to 30 milligrams once in a day. Oxybutynin in some countries also comes in a patch formulation, and it is known as oxytrol. So one patch comes as 36 a week. Next group of medication is solid daily, can go up to 10 milligrams in a day for kidney or liver dysfunction. The next one, immediate release and extreme release formulation. For immediate release formulation, we give 1 milligram twice a day, go up to 2 milligram twice a day if the kidneys or livers are not functioning well. And for severe renal impairment, give 1 milligram twice a day and avoid in hepatic impairment. For the extreme release formulation, we give 2 milligrams once in a day, and we can go up to 4 milligrams once a day. For kidney dysfunction, the other medication that can be used is trosmium, 20 milligrams a day, and can go up to 20 milligrams 2 times a day. Maximum 20 milligram daily for severe renal impairment, and avoid using, like before, in severe liver disease. In older age, it's good to give 20 milligram daily and not go off from there. Moving on to the next slide. Here we'll discuss a bit more about the pharmacokinetics of the medications that we just discussed before. So the first thing is about bioavailability. So the medication is with the maximum bioavailability, as you can see from here, is solifenacin, followed by solifenacin and tolterodine. Sometimes it's a very common question that patients ask: is the medication affected by food? So the answer is yes. And it is seen that there can be increased serum concentration of oxybutynin of around 1/4, 25%. And also it's good for trosmium, like 70 to 80% reduced absorption with high fat meal. So better to avoid. What is the time to peak concentration? So the fastest working this medication group is oxybutynin. It's 1 hour for immediate release, and also tolterodine more than 2 hours. It is as it suggests. It takes around 6 hours. The next one is fluvoxamine, which starts its peak concentration, reaches around 2 hours, and darifenacin takes time, and then is trosmium, which takes time as well. The half-life of medication is important to know about the elimination time for the medication. Half-life for this medication, as you can see, is solifenacin. It's quite high. Half-life of the immediate release formulation of oxybutynin and tolterodine gets a big one, because elimination needs around 5 to 6 hours, I presume already. The next one is about excretion. So trosmium is excreted mostly by the feces, and which gets excreted the most is tolterodine, followed by darifenacin and fluvoxamine. So you have to be careful, as we spoke before, about its usage in kidney dysfunctions. Metabolism 2D6 and is an active metabolite in the case of darifenacin. In the case of fluvoxamine, it is an inactive formulation which is actually converted to the liver case for oxybutynin. For solifenol, there is not much data available. Talks about incidence of adverse event associated with anticholinergic agents. So as you can see, the most important side effect that patients might tell us is about dry mouth. And as you can see, dry mouth is a big complication for oxybutynin and for dadifenyzine. Important to note that oxybutynin transdermal system, the adverse event, apart from dry mouth, also includes local erythema recycle rash or mercury at the application. It's not in the transdermal system. Constipation can be a big problem in palliative care, and 8 are not as frequent as these two main complications like dry mouth and constipation, but they are there, like abdominal pain, blurred vision, drowsiness, headache, and dry eye. Moving on. So this is a slide that is quite updated from the medical data from India. Like what is the cost of this medication if you want to use in your practice? This is regarding the more oriented side in the session. So if you want to use, you can actually focus on the economics of using. Then look at this thing. So as you can see, the most economical contributing as we around 4.90 rupees per dosage. You gotta use 3 times a day. Apart from that, almost of similar range will be flavoxate or Urispas, darifenacin or Enablex. Then oxybutynin, the extended release formulation, you see is a bit more expensive than the immediate release formulation. And then comes the other ones which are a bit expensive. Then trosmium, also known as Sanctuary, is a bit more expensive. And the highest in this category is actually drolterodine, long-acting, also called as detrol AA. So, in short, oxybutynin, and the highest expensive in this group will be drolterodine, long-acting. So it depends on your choice and patient preference, which one to be used. If there is one thing that I'd like to focus is the think about the choice of medication, think about the side effect, think about the medication, discuss with the patient about the about the duration, how long the medication works in the body. And finally, after giving them the choices, we ask them finances, like which is the medication that they can afford, because these medications generally we use it for quite some time. So the medication that they can afford, and they can keep on. So that makes your prescription. I'd like to say thank you for your patient listening. Have a good day.
I would request the tech team to kindly start the video of the last session, last lecture.
children. I'm Dr. Megan Doherty, and I'm the Program Director for Pediatric Palliative Medicine at the Children's Hospital of East, Director with Two Worlds Cancer Collaboration. The objectives for today's session are neuropathic pain and describe the main causes in children with life-threatening and important non-pharmacological components of the management of pediatric neuropathic pain, and to describe the evidence and provide a step-by-step approach for or disease of the somatosensory nervous system. Neuropathic pain is a clinical description and not a specific diagnosis, and it requires a demonstrable lesion or disease. Somatosensory refers to information or sensations received from the body itself versus the external world. A lesion commonly either by diagnostic investigations or obvious trauma. And disease refers to something where there's a clear underlying cause for the lesion that is known, such as if a patient had a stroke or has a genetic abnormality. Common causes of neuropathic pain include cancer in children. This causes tumor invasion or compression, as well as nervous system tumors and cancer treatments, including vincristine and cisplatin. Traumatic injuries to the spinal cord or nerves or amputation can also lead to neuropathic pain. Neurological and neuromuscular diseases, including those listed below, are less common causes, and there are some very rare metabolic and genetic diseases that can cause neuropathic pain, including Fabry's disease, erythromelalgia, and paroxysmal extreme pain disorder. When considering the treatment of neuropathic pain, we must first conduct a proper assessment. There are several scales that have been developed for use in adults, such as the Neuropathic Pain Scale and the Pain Quality Assessment Scale. But unfortunately, there are no validated pain scales for neuropathic pain in children, and studies in children have used the validated tools which are used for acute pain, including most commonly the FACES Pain Scale Revised, the Revised FLAC, and the Visual Analog or Numerical Rating Scale. Include assessment of the descriptions that the child gives of the pain, including terms such as numbness, tingling, burning, electric shock sensations, and shooting pain. And signs and symptoms including allodynia, hyperalgesia, defined here. When we move on to think about the multimodal analgesia for neuropathic pain, we can think about first line and second line. First line includes the use of opioids and non-opioids, including paracetamol and non-steroidal anti-inflammatory. Of by the clock, by the child, by mouth, and by the ladder. Second-line treatments include adjuvant medications, which we will discuss in detail, and invasive approaches such as regional anesthesia and neuroaxial anesthesia. It can also be helpful to consider the management of neuropathic pain using the 3P approach. This includes consideration of psychological, pharmacological, recognition that all three work together to contribute to a best pain management plan. Let's look at this case example to help us understand how to manage neuropathic pain. Sammy is a 12-year-old girl with a bone tumor. It's a Ewing sarcoma, which has progressed despite chemotherapy, surgery, and radiation. Last month, imaging revealed several metastases in her lungs, liver, and a large primary tumor in her left hip, infiltrating the spinal cord and compressing her left sciatic nerve. She presented to a clinic today with 1-week history of worsening pain, weakness, and urinary incontinence. She described shooting pain hundreds of times per day down the top of my leg and down into my foot. On examination, yes, she has allodynia of her foot and leg. Symptomatically, Sammy's symptoms were suggestive of malignant spinal cord and sciatic nerve compression, which was confirmed by MRI. The team considered urgent radiation for the spinal cord compression, but it had been more than 1 week already, so it was felt it would be ineffective. She was prescribed oral dexamethasone and morphine, which improved her neuropathic leg pain. Dexamethasone could be useful for treating both nociceptive and neuropathic pain. The mechanisms for pain reduction that have been proposed include reducing inflammation and peritumoral edema. Dexamethasone is preferred over other steroids due to minimal mineral twice per day. Typically, 0.1 to 1.5 milligrams per kilo are used, with a maximum of 10 milligrams daily. This is physical and psychological strategies, as we mentioned in the conditioning and allowing the family and be integrative medicine can also be considered, including therapy. She used deep breathing, happy place in her medications for children with moderate to severe pain, as they typically require opioids even if the TTs for neuropathic therapies that we commonly use for neuropathic pain. There aren't any comparable studies for children. However, for children with mild pain, opioids are appropriate. If pain can be controlled with simply non-opioids such as NSAIDs, paracetamol, and perhaps the adjuvants such as amitriptyline or gabapentin. Adjuvant analgesia refers to medications which are added to primary analgesics to further improve pain control. The recommendations below are based on randomized controlled trials, as there's limited evidence to guide us from pediatrics. Let's first talk about considered to have equal efficacy to tricyclic antidepressants for children. The NNT is reported from adult literature to be between 2.9 and 3.9. The mechanism is inhibition of the excitatory glutamate system at the level of the dorsal horn. Starting doses are between 2 to 5 milligrams per kilo per dose, with titration. A maximum titration can be up to 24 milligrams per kilogram per dose. Side effects, which are uncommon if the patient is titrated slowly, include fatigue, ataxia, nystagmus, dizziness, headache, and peripheral edema. Pregabalin is a newer gabapentinoid that can be used if gabapentin is not intolerable side effects. There's no evidence of superior in meta-analyses from adults, and gabapentin is generally at a low dosing in the literature, but general expert recommendations about dosing are listed here. Maximum doses would be up to 6 milligrams per kilo per dose, up to 300 milligrams twice per day, and we advise to wean off slowly to avoid precipitating seizures. It's also important to note that tricyclics and gabapentin mechanisms are completely separate. The management of babies 0 to 6 months who have advanced cancer or other life-limiting conditions requires special expertise. Gabapentin is a recommendation for children this age, and it has good effect for neuropathic pain, feeding intolerance, which leads to what we call visceral hyperalgesia and neuroirritability. Dosing is hourly, and that's found to be more effective than Q8 hourly dosing in this population, and it's due to more rapid metabolism of the gabapentin in this. 4 milligrams per kilo every 6 hours are generally used, and there's a slow titration up to a maximum of 15 milligrams per kilo. Tricyclic antidepressants are one of the best known and studied adjuvant medications for neuropathic pain in adults, with an NNT of 3.1. Amitriptyline and nortriptyline are among the best studied. These medications act by blocking reuptake of serotonin and norepinephrine, which may stimulate pain or inhibiting pain transmission up the spinal cord. Adverse effects are common, including dry mouth, sedation, and QT prolonged. With an adult dose of up to 5 milligrams, 0.4 to 0.5 milligrams per kilo, QHS. Titration is generally under the age of 6 months. Blockers are another important category of medications, and these are known as a dissociative anesthetic, but is also an analgesic at low doses. Are listed here. Side effects, which are generally not present at low dose, include intracranial hypertension, tachycardia. Often we give benzodiazepines. Is an important component of our neuropathic pain treatment for children. It's a receptor antagonist, and there's also some serotonin and norepinephrine. It has a very long half-life, so this is a risk of accumulating dosing and should be only administered by experienced clinicians. But an advantage is that it provides both an open and it's safe in renal and liver disease. There are a number of other adjuvants that can be considered in particular situations in pediatrics. Alpha agonists such as clonidine and dexmedetomidine, and palliative chemotherapy or radiation. Other for patients with muscle spasticity, which is contributing to their pain. These include baclofen. Lidocaine can be given by continuous intravenous infusion, and cannabinoids. And systematic reviews recently have shown that and opioids allows in some countries there are 5% lidocaine and ketamine creams are also relatively simple for pharmacists to compound and can be used similarly to the patch. Topical capsaicin can also be used. This can either be used as repeated application of a low dose of the cream or a single application of a high dose patch. Because of local skin irritation, burning, and stinging that occurs, EMLA or another topical anesthetic cream should first be applied to the skin. Here you can see a summary of neuropathic pain in pediatric palliative care, including a suggested stepwise approach, which is based on expert recommendations since there's no of methadone can be done as a third step, followed by the use of either a tricyclic antidepressant or gabapentinoid, and then a combination of the two. The next step would include a lidocaine patch if the pain is localized, followed by an NMDA receptor channel blocker. And other medications can be considered at this stage, including benzodiazepines, alpha agonists, IV lidocaine, depending on the patient's clinical scenario and what's available in your setting. And if all of these steps are not generating an appropriate degree of pain control for the patient, you can start to consider referral to pain and palliative care specialists, specifically related to potentially regional anesthesia. So in neuropathic pain, which we defined as pain caused by a lesion or disease of the somatosensory nervous system. We discussed the 3P approach, which you can see the image for here, which I think is very important for helping us remember to incorporate not only pharmacological, but also physical and psychological components of treatment, which will help our patients the most. And then we talked about a number of medications, including opioids, gabapentinoids, and tricyclic antidepressants, and a variety of other agents, noting that there's very limited evidence in pediatrics for any of these agents, and there is some evidence from adults and some expert recommendations which can help guide us.
Now I request Mrs. Saroja to take on the further proceedings.
Megan, how much yes, sir, thank you. And it was a very enlightening talk by all the doctors who have spoken on the topics of antimuscarinics. Hello.
So everybody is moving the heads. So you please move, Saroja. We can hear you.
Hello. Am I audible?
Yeah, you are audible very much.
Yeah. And I would like to ask Dr. Megan, like how much? Yeah. I would like to ask Dr. Megan, like how much dosage of
Sorry, I only caught the beginning of the question. I didn't catch which medication you're asking me about.
how much dosage of high dose of morphine have you given for children?
Sorry, so the question is the dosing of morphine for children?
Yeah.
Yeah, so I didn't focus on opioids just because that's probably a whole separate discussion. But in general, for children, oral morphine dosing is 0.2 to 0.3 milligrams per kilo every 4 hourly. For children over 1, under 1, I would start a little more conservatively with 0.1 milligrams per kilo per dose. But it is a key part of your neuropathic pain treatment just because we know that it is effective. But typically, we may start them also on gabapentinoid or a tricyclic antidepressant because we know that there's a time lag there with titrating up and perhaps has some opioid sparing effect. But again, it's all based on expert recommendation and evidence from adults. Unfortunately, there just has been very, very little study of the pharmacology of neuropathic pain in children.
Thank you. Just to highlight, like where I work at Kidwai Institute of Oncology, where we have the Regional Cancer Center. We have used, I think 20, we have a case of Ewing sarcoma. So we had used up to 20 milligram every 4th hour for that patient, just to highlight that I just mentioned it.
Yes, definitely is appropriate. You would starting doses would be, 0.2 to 0.3, and then you titrate upwards, and you can get up to quite high doses. And if you have access, I know that there are at least a few centers in India that have access to methadone, and Hyderabad has been using methadone for quite a while for pediatric patients, then that can be really a good option once you get onto high doses of opioids, because then you will reduce your opioid tolerance and also get the impact of the NMDA receptor effects.
Thank you. Any questions are there?
My question to Megan, could you listen me, hear me? Yeah, regarding the cannabis, use of cannabis for this pain. So in Multinational Association of Supportive Care Cancer, we are preparing some guidelines regarding cannabis use and the evidences with cannabis. So I'm just interested because we were working on this particular field. I am more or less concerned with the GI symptoms and cannabis. some other team is preparing the data for this pain management and other things. So I just want to ask you, what are the cannabinoid derivatives which could be used or which has some favorable outcome with pain?
Yeah, so it's quite tricky with cannabis. Like we did publish one study that we've done in Ottawa looking at our patients who used cannabis oral extracts. So they're legalized in some countries. They're legalized in Canada, where the plant, the flower, which is where it has the high concentration of CBD and THC, which are really the active cannabinoids, the main ones, that it's extracted from that into an oil, and then the oil is consumed orally. So you can put the oil into capsules, or you can just take it orally. It's very concentrated, so you don't have to take very large volumes. So that we know that helps with spasticity, especially the original studies were spasticity in patients with multiple sclerosis, and pain related to the spasticity and perhaps dystonia, and has an opioid sparing effect. So if you initiate that treatment, then you can probably reduce the amount of opioid your patients are on. And there's a systematic review for that in adults. The problem with the cannabis studies overall is that there's a high degree of variability in the products that are used. So sometimes a study is done with like a high CBD oil or a high THC oil, and those are quite different because actually a different compound that is your primary compound. But in these extracts, you also get a mixture. You don't just get pure one thing, you actually get some of both. So all of this makes it very hard to interpret the literature at this point on exactly what to recommend to patients. But the general expert recommendation is products that are either mixed, having sort of equal amounts of THC and CBD, or higher in the CBD component would be recommended. And then in some countries, there are synthetic cannabinoids available. So the two main ones that people might be aware of is nabilone, which is a synthetic derivative of THC, which has been studied and is shown to be effective for chemotherapy-induced nausea and vomiting in children. Actually, that's been studied. And then obviously there's been some studies of that in adults as well. And then there's a spray that is available in a number of countries, which is a combination of THC and CBD in an oral spray, and then it's absorbed probably through the mucosa, or a little bit is swallowed and absorbed that way. And it's derived from plants, but highly kind of purified. So it's almost like a medication in that you know exactly what's in it, versus these oral extracts that are the oils. Those are they're not really a pharmaceutical grade product in that they have a number of compounds in them, CBD, THC, and about 60 other minor cannabinoids. So at this point, I think that there's still a lot of research to be done. So it's an area that's challenging to really make very strong recommendations. But we are starting another study, a multi-center study that's being run out of Australia, that will hopefully give us some more information for pediatrics in the next year or two once we collect enough patients.
We are particularly concerned about the side effects of the cannabinoid derivatives, because most of the cannabinoid derivatives, though it is being thought that this might be free from side effects or something like that, but in systematic reviews, when we are doing those systematic reviews, we are finding quite a lot of side effects are occurring with has been reported. Maybe the actual incidence is more because many of the cannabinoid studies has been done in early 80s or early 90s. So it is a challenge to conduct systematic studies because most of the studies are very old and the newer studies are less. And the other thing is typical of these cannabinoid derivatives in some oil preparation. So the standardization becomes difficult about the concentration, exact concentration of THC or the other compounds, whichever is there. So it may be difficult for administration part of also, because we don't know what should be the exact dose. So how are you managing these situations regarding the dose, particularly with this oil? And how are you managing the adverse events or side effects?
Yeah, so I mean, in terms of dosing, when we do the studies, we are typically
available in India for medicinal use, but to know that cannabis is available in other forms and it is consumed for other reasons, for a high. by many
Yeah.
people, but not in cancer till now. But in that case, we are gaining knowledge from you people who are actually using cannabis. The problem I already said, I shared with you that most of the data available are from very old clinical trials, which many of those are not very standardized. Not the intervention, not the objectives, or not the statistics. So there are a lot of gap in the knowledge. Probably you are going to address those gaps in near future. So over to Dr. Rupesh.
Yeah, thank you, Dr. Sandeep. I would like to thank the chairperson, Dr. Sandeep, and Mrs. Saroja for wonderful conducting the session. And thanks Dr. Meghan, Dr. Nikki, and Dr. Arun for delivering their lectures and giving us and enlightens us for the topics they have covered. And I would like to thank the organizers for giving us the opportunity. And we want to close the session. Thank you everyone. I say good night for today. Thank you.
Thank you, everyone. Have a nice evening.
Thank you, everyone. Yeah.
Dr. Sandeep, I can send you a few articles because we've done, we have a few things, and I just did a presentation on cannabis use for my colleagues. So I've kind of looked at all the literature very recently, like last week.
Shall I share my email ID with you in this chat
Yeah,
box?
if you put it in the chat there, then I can send you a few things to look at. Perfect, thanks. I'll send you some information and stuff later today. But I think, at this point, like in our approach has been, because in palliative care, the risk of harm is less because you're not using it for years and years. Usually, patients are not going to be alive that long. Then there's more of a balance of maybe it's appropriate to try. And some medications, like I was talking to psychiatry, and they want to try it for like aggressive behavior in children who are, otherwise they're using antipsychotics, which they feel probably the harm of those is higher than the risk of using, high CBD cannabis products, which are probably relatively safe, to be honest. So anyways, don't get me started. I can go on for a long time about cannabis.
Well, it's nice to talk to you because you are actually dealing with cannabis. Again, I will say the same thing. And thanks to Saroja, Dr. Rupesh, and the tech team for all the efforts you made to make this conference successful. And the session went well. So thanks again, Megan. Good night. So you were probably having a good day.
Yeah.
Thank you again. Yeah, I'm going to go start my day, see all my patients.
Good day for Megan, and good night for Saroja.
Yeah. Thank you, sir.